you, sir. Thank you.
So today we are going to deal with disorders of calcium and metabolism. And you guys see the beauty of the calcium, you know, the corals and all these buildings like that, you know, partly due to calcium. So everyone knows that it's an important cation. And most would think that it is the main role of calcium is to give the structural integrity of our body by being a major constituent of our bone. But it has many other roles, particularly it's important in membrane excitability of muscle and nerves. So there can be issues in muscle contraction and nerve conduction if the calcium levels are too low or too high, and cofactor for many enzymes, including blood clotting, release of enzymes, hormones, and vesicles. And also because of all these excess and deficiency, both can lead to many disease states. This is roughly the equations for calcium balance. Usually intake is equal to output, and it's about 1000 milligrams. The main organs involved are the bone, intestines, and the kidneys. We will discuss that bit later, you know, in more detail. And these are the generally rough numbers. Generally, you know, it's important to remember that about 99% or more of our calcium is in our bone. The extracellular fluid is less, and also among the calcium that is in our circulation, the ionized calcium is what is important for immediate action. That's a free calcium, like the unbound hormones. Bound calcium, which is bound to mostly to albumin, is about 50%, and then some of the calcium is complexed with other anions like phosphate, citrate, lactate. And also you can imagine that if there's too much of any of these, you can get a low ionized calcium, right? And then there are various equations based on, you know, calcium phosphate product and so on, which are important things if you are going to, you know, study detailed biochemistry and various other things. But for endocrine module purposes, these are not going to be too much important. So just to recap your calcium metabolism, I told you that most of the calcium is in the bone, and we have the calcium in the extracellular fluid. And it is mainly under the influence of a hormone called parathormone, or PTH, which is secreted from 4 glands situated in the posterior aspect of our thyroid gland, 4 tiny glands. The main action of the parathormone is to keep the level normal by bone resorption, resorpting calcium from bone, and then also interfering with calcium metabolism in the kidneys. In the kidneys, calcium metabolism is like affected by reabsorbing calcium from the kidney tubules, and also for there is a step in the vitamin D metabolism that is vital, that is 1-alpha hydroxylation. That step happens in the kidney. 125 dihydroxycholecalciferol or 125 vitamin D3 is the active form of vitamin D. This final activation process happens in the kidney. So the vitamin D is also very important for calcium metabolism. This stimulates absorption of calcium and also phosphate from our food in the intestines. So that is how like very integrate balance of calcium metabolism is maintained in the body in normal physiology and homeostasis. Again, I think the same thing. It gives you what are the, you know, positive steps, what are the negative steps. So I'm not going into detail here. You can you know, you get a recorded form, you can also go through leisurely and again read this. Then vitamin D metabolism, I think you would have learned this at some time or the other in your medical curriculum so far. We have the 7-dehydrocholesterol, which in the skin, when it's exposed to ultraviolet light, is changed to cholecalciferol, the first step in the vitamin D synthesis in the skins. And then this is converted to dihydrocholecalciferol, 25 hydroxycholecalciferol by 25 hydroxylation, which occurs in the liver. And another hydroxyl groups is added by this step, that is happening with 1-alpha hydroxylation. The 1-alpha hydroxylase comes from the kidney, and this is the active form of vitamin D. Again, the same thing for you to just recap. So coming into disorders of calcium metabolism, there are two major groups of disorders: the hypocalcemia and hypercalcemia. Hypocalcemia, as the term means, it's deficiency, and it can have many causes. As there are many reasons, many mechanisms involved in keeping the calcium balance, the main hormone is, I told you, PTH. So it can be PTH related. So any hormone, if it is dysfunctional, it can be the deficiency or resistance. So if you understand these principles, you can apply for any situation. So any hormone like insulin also, we will discuss later on, it's either deficiency or resistance. And again, vitamin D, very important, vitamin D deficiency or resistance. Very rarely some instances occur where there's excessive deposition in the skeleton. We will discuss this as we go on. And then I told you that some of the calcium is complexed with anions in the and the proteins in the circulation. So if there is increase of these, any of these, suddenly without time for stabilization, there can be sudden reduction of calcium, particularly ionized calcium in the circulation. And also if there is inhibition of bone resorption, particularly if certain drugs can interfere with bone resorption. So I told you that bone is the reserve of calcium. So constantly calcium is deposited in the bone, and also it's taken out from the bone to maintain calcium balance. So if there's inhibition of bone resorption, you can get hypocalcemia. PTH related disorders, the common things are the deficiencies, and sometimes it can be resistance. So the destruction of the glands can happen due to autoimmune processes, autoimmune hypoparathyroidism. Surgically, if you remove the parathyroid gland, sometimes this can happen inadvertently when you do a thyroidectomy. And if there's infiltration of the glands, and radiation, sometimes also in thyroid cancer and so on. And then there are congenital developmental disorders where the parathyroids does not develop properly. I will discuss this as we go on. And then certain other deficiencies like magnesium deficiency and also genetic defects in PTH secretion, there can be impaired secretion. And also I told you, sometimes you can get target organ resistance. We call this pseudo hypoparathyroidism. Parathyroidism is pseudo, action happens but the hormone is there. And in hypomagnesemia, another mechanism of hypocalcemia is because it leads to, again, target organ resistance of the PTH. So these are the key points. Rare disease of hypocalcemia. The symptoms can range from paresthesia to muscle cramps to seizures, and also death, mainly due to laryngospasm. Most common cause is injury or removal of the parathyroid glands in anterior neck surgery, like in thyroidectomy. And then there can be other genetic and autoimmune causes of isolated deficiencies. And also hypoparathyroidism often associated with basal ganglia calcification due to the interference with the calcium and phosphate product, cataract, and some neuropsychiatric symptoms. And the treatments, and we will discuss these as we go on. The Digeorge syndrome is a problem in the embryogenesis where there's defect in the formation of these branchial arches or branchial pouches. I think you guys have learned this in embryology. And then there's problems in the mandibles, development of the mandibles. Then there can be thymic aplasia, cardiac issues, immunodeficiency because the thymus is involved in immune activation. So this is a rare syndrome where you can get hypoparathyroidism. And in the autoimmune hypoparathyroidism, there can be other associated autoimmune phenomenon of other glands like thyroid and so on. Again, due to various mechanisms, they can get mucocutaneous candidiasis, particularly in the mouth, oral thrush, esophageal thrush, and then they also can get cataract, I told you, and then these are basal ganglia calcifications, and also immunodeficiency. Hypocalcemia, I told you, it can, hypomagnesemia can cause both failure of secretion of PTH and end organ resistance. This is a reversible cause of hypocalcemia, and particularly in people with chronic malabsorption, alcoholism, this is common. And if particularly in someone who does not respond to therapy, you need to always be aware that it may be magnesium deficiency. And then there are calcium sensors, particularly the calcium sensors in the parathyroid glands and renal tubules sense the level of calcium, and then in the PTH leads to PTH secretion. Imagine what will happen if this sensor is set up or its threshold is set down. It can also affect the calcium metabolism. So PTH secretion occurs at a lower level of calcium if the set point is made lower, and vice versa. So this can cause hypercalciuria and also hypocalcium if the threshold is set at a lower level. This is for interest sake. We don't question too much on this thing at your level, but it's very fascinating. You can see the calcium sensing receptor and the parathyroid glands and the PTH, and this is very fascinating phenomenon. In the hypoparathyroidism, there is end organ resistance to PTH. So you have your PTH, but the organs does not respond. In this clinical syndrome, these people are generally short, and they are also chubby, obese, and there is a characteristic phenotype where you get short fourth metacarpal, and as a result, the fourth finger is short, right? You see this short fourth metacarpal. And so you ask the person to sort of, make a fist. You can see this nicely. So it's called Albright's hereditary osteodystrophy. So this is not uncommon. You see this. And there's another syndrome called pseudo hypoparathyroidism. You see these features particularly in the hands, but there's no biochemical issue. So actually there's no issue in calcium, normal calcium metabolism. You only see the skeletal abnormalities. The vitamin D related causes of hypocalcemia are broadly categorized as ricketts or osteomalacia. based on whether it occurs in the children before the bones are mature, you call it rickets. And if this happens in the old people after the bone epiphyseal maturation occurs, we call it osteomalacia. So this can happen due to vitamin D deficiency. We know that vitamin D comes from diet, sunlight, and also can happen with malabsorption, because vitamin D is a fat soluble vitamin. So if there's fat malabsorption, you can get vitamin D deficiency. And if there's in the liver disease, you can have impaired 25 alpha hydroxylation. And also in kidney disease, you can have 1 alpha hydroxylase deficiency, and then vitamin D metabolism affected. And then there are other inherited disorders where there is problems in 1 alpha hydroxylation, and also where there is vitamin D deficiency. This one is called vitamin D dependent rickets type 1. The problem is 1 alpha hydroxylation. And then there is resistance in the vitamin D dependent type 2. And certain drugs like phenytoin and so on also can cause vitamin D resistance. Sometimes, not very commonly, you can get excessive deposition in the skeleton, particularly if there are osteoblastic deposits from cancer. And also there is this syndrome called hungry bone syndrome. This occurs if you suddenly take out parathyroid from our system in a person who have hyperparathyroidism. Imagine in hyperparathyroidism, there is excessive resorption of bones, and this leads to actually hypercalcemia. You immediately take off parathyroids and make the parathyroid level extremely low. The bones suddenly revert because the bones have been, devoid of calcium by the action of parathyroid. Suddenly bones want to take back all the calcium it lost. It's called hungry bone syndrome. And then your calcium in the circulation gets resorbed to the bones, and you can get severe hypocalcemia and can be even life-threatening. Sometimes you can have chelation of calcium, particularly in the time the citrated blood was used. Citrate prevents the calcium from being free, and it prevents blood clotting. And then EDTA is also having similar action. Fatty acids, particularly a lot of fatty acids gets liberated to the circulation in acute pancreatitis. And if you infuse phosphate, it can bind to calcium. Then drugs like foscarnet, fluoride, all can bind to calcium and give rise to hypocalcemia. So in a patient with suspected hypocalcemia, you need to be aware of symptoms. They can get numbness around your mouth, circumoral numbness. They can get cramps, tetany, laryngospasm, which can cause death, psychosis, and also convulsions. You need to get clues for etiology, family history, recurrent infections like in autoimmune hypoparathyroidism, mucocutaneous infections, whether there's a history of neck surgery, irradiation, and other related illnesses. The classic signs are, one thing is called Chostek's sign, where if you tap in front of the ear, uh, the facial muscle goes into spasm. It's called Chostek's sign. And also, if you get a blood pressure cuff inflated in between systole and diastole, this leads to stagnation of the blood, and the calcium is bound to the albumin and other proteins, and ionized calcium can become further low, and this leads to the characteristic this sort of contraction of the muscles. We call this Trousseau's signs. In severe forms, there can be papilledema, and then also you can get other etiological clues. In investigations, you need to confirm biochemically whether there is hypocalcemia. And particularly calcium, I told you, if you do total calcium, it reflects ionized calcium and the bound calcium. So if the albumin levels are either high or low, this can affect the bound calcium level and the total calcium level. So if you are doing total calcium, you have to correct it for the serum albumin level. There is a equation, again, I don't expect you to remember that, but you need to remember the phenomenon or the principle that when you are doing total calcium, you need to make a correction for albumin level. But we can do the ionized calcium. Nowadays, a lot of analyzers are there to measure ionized calcium. This problem of the albumin correction does not come into play. And also you might need to do the other investigations to find the underlying cause. So the calcium level is done, and if this is low, you need to look at the phosphate level. Usually if there is hypoparathyroidism, the calcium level will become low. So you can suspect that the patient is having hypoparathyroidism. Again, I told you about the importance of magnesium. We need to check the magnesium. And then usually renal function also is done, because I told you that 1-alpha hydroxylation occurs in the kidneys. So if the kidney function is affected, this is low. So this can be a cause for low calcium. And then based on these tests, you can get a clue whether it is PTH related or not. If it looks like it's PTH related, where the calcium is low, phosphate is high, magnesium is not much abnormal, renal function normal, then you need to do the test for intact PTH. Then you can come into exact diagnosis. Intact means in the PTH molecule, there can be sometimes, PTH molecules related peptides secreted by cancer cells. So in the intact PTH, you check both ends of the molecule. And again, this algorithm gives an idea how to investigate for hypocalcemia. And then if somebody has low phosphate, it is due to vitamin D deficiency, either rickets or osteomalacia. And in such situations, there is compensatory increase of PTH level. And also the alkaline phosphatase, bone alkaline phosphatase increases. But if it is high, it can be, if the renal function is normal and the PTH is low, it's typical hypoparathyroidism. If the PTH level is high or PTH level is normal, it can be, particularly if the PTH level is normal, where there are rare causes of hypoparathyroidism, but it can be also activating mutations of the calcium sensor. But if the PTH level is high with normal renal function, there is evidence for end organ resistance. And here I told you that we need to do, if this picture is the cause, we need to do vitamin D levels to come into diagnosis. In the management of hypocalcemia, the method of management depends on whether somebody has very mild asymptomatic hypocalcemia or whether somebody has symptomatic or severe hypocalcemia. If it is mild, if the levels are like this, you can increase dietary calcium intake and also give vitamin D supplements, and that might most probably get corrected based on the cause. And if it is symptomatic and severe hypocalcemia, it's a medical emergency. and you need to give intravenous slow calcium infusion in the form of calcium gluconate or chloride. But if there's doubt, you need to also check for magnesium deficiency, or sometimes the severe forms, there is no harm in administering magnesium, slow magnesium, if there is no, particularly no renal failure. But if somebody is having renal failure, they can have magnesium, high magnesium levels. You have to be careful, and it can cause magnesium toxicity. There can be states of chronic hypocalcemia. In those situations, what we do is we give oral replacement, particularly in the very severe forms. You need to give active forms of vitamin D. They are the alpha calcidol is 1-alpha cholecalciferol. Calcitriol is 125 dihydroxy cholecalciferol. And then sometimes, particularly in hypoparathyroidism, you can go sometimes up to very high doses of these active forms of vitamin D. Along with that, you need to give calcium supplements, usually again fairly high doses, and severe hypoparathyroidism after surgery. And the plan is to achieve low normal serum calcium levels, because if you give too much of these, you can get hypercalciuria. I told you calcium intake is usually balanced out by calcium loss. So if there's too much of calcium in the urine, what can happen is you can get kidney stones and also calcification of the renal tubules. And some in other countries, not widely used, subcutaneous synthetic PTH has been used with less risk of hypercalciuria, but these are very expensive treatments, and again not in wide spread use still. And then how to monitor, actually I don't think that you need to know this in detail, but particularly you can read this leisurely to get a bit of a in-depth understanding of the situation. But again, this little beyond your undergraduate level, this is for additional reading. Hypercalcemia, there are again excessive bone resorption, or excessive intestinal absorption, excess intake, excess renal conservation, or rare other forms. These are the common pathological mechanisms of hypercalcemia. Excessive bone resorption can occur commonly due to hyperparathyroidism. If the main issue is autonomous secretion of parathyroid hormone from the parathyroid glands, we call it primary hyperparathyroidism. And then there is this entity which is also less common, called tertiary hyperparathyroidism. Now, I told you that in vitamin D deficiency, you get stimulation of the parathyroid gland to secrete more PTH. And then this is called secondary hyperparathyroidism. While the calcium level is low, you get higher secretion of PTH. We call this secondary hyperpara. Sometimes when there's long-standing secondary hyperparathyroidism goes on, the gland becomes autonomous and starts secreting parath hormone irrespective of the calcium level. So in that scenario, at that stage, the calcium level starts going up. We call it tertiary hyperparathyroidism. These are commonly in patients with long-standing chronic kidney disease and long-standing vitamin D deficiency. And then some malignancies secrete PTH-related peptides. So these have similar actions to PTH and leads to excessive bone resorption and hypercalcemia. Because of this reason, I told you that we need to check for intact PTH molecule if you want to diagnose hyperparathyroidism, because PTH-related peptide, one of its ends is similar to PTH. Bone metastasis leads to excessive bone resorption. And also, if somebody suddenly gets immobilized, particularly like in space travel, astronauts, don't need to have the gravity, so you don't need to have strong bones. The body then responds by increasing calcium output from the bones. Then you can get a mild hypercalcemia. uh, this excessive intestinal absorption of calcium happens particularly when there's too much of vitamin D, like in vitamin D intoxication. Particularly, this used to be common when people were treated with milk and alkali. Milk has a lot of vitamin D and calcium, and alkali has a lot of calcium, like calcium carbonate and so hydroxide and so on. It's what's called milk alkali syndrome. People were used to use milk and alkaline agents to treat gastric acidity in the era where there was no proton pump inhibitors, and then they used to get excessive calcium, hypercalcemia. And then certain disorders like sarcoidosis and lymphoma also produces active forms of vitamin D, and that also can cause hypercalcemia by increasing intestinal absorption. Uh, then there is this entity called familial hypocalciuric hypocalcemia. The problem is in the intestinal calcium sensing receptor. And what happens is there is less excretion of your calcium in the renal tubule. And then as a result, the body calcium levels go high. But these don't lead to severe forms of hypercalcemia. The thiazide diuretic also has a similar effect. It interferes with renal excretion of calcium, so it can lead to hypocalciuric hypocalcemia. And Addison's disease also, which is due to adrenal insufficiency, leads to hypercalcemia by reducing renal excretion. I told you about primary, secondary, and tertiary hyperparathyroidism. This is further explained with examples. Primary is when the problem is in the parathyroid gland due to either adenoma or hyperplasia, and you have high calcium and high PTH. Secondary is when there is hypocalcemia chronically, renal failure, osteomalacia, you have low calcium and high PTH. Tertiary is after prolonged secondary hyperpara becoming autonomous. Again, biochemical picture is similar to the primary, but if it is due to renal failure, if you do the renal functions, you can detect renal failure. And if it is due to long-standing vitamin D issues, if you do the vitamin D, you can diagnose concomitant osteomalacia. So what are the consequences of hypercalcemia? You can get polyuria, dehydration, because too much calcium interferes with water reabsorption in the kidneys, and also get polydipsia. And then it can affect the ECG. You can get shortened QT interval. You can get hypertension, anemia, and a lot of neurological disturbances, because that interferes with membrane excitability, weakness, lethargy, hyporeflexia, muscle twitching, confusion, psychosis. And long-standing too much calcium can lead to kidney stones and calcification of soft tissues like cartilage and the renal tubules. And also leads to increased gastrin secretion, and as a result HCl secretion in our stomach, and lead to peptic ulcer disease. People used to call this bones, stones, abdominal groans, and psychic modes, because it leads to bone pain, because when there's too much of calcium resorption, your bones become brittle and bones can fracture. Bones, stones, renal stones, they can cause ureteric colic and so on. and then abdominal groans due to a peptic ulcer disease, and psychic moan because it can lead to psychosis. So investigation of hypercalcemia, you need to exclude that there are drugs or immobilization. And then you can have two scenarios. You need to do PTH assay in a person with hypercalcemia. So if somebody has uh, hypercalcemia, usually typically they have high PTH, rarely they can have high normal PTH. Then you need to suspect hyperparathyroidism, because in a normal person, the normal mechanism should be the PTH should get inhibited. But in a normal person with hypercalcemia, if you have high PTH or near high normal, it should be hyperpara, or this phenomenon called familial hypocalciuric hypocalcemia. Also, what happens is there is the setup point is increase for PTH sensitivity in the calcium sensing renal tubules. So as a result, you need to have high PTH to exert its effect. So this leads to low calcium excretion in the kidneys, but the calcium level has to be high to increase the PTH secretion in the parathyroid gland. This is rare, but you need to remember particularly the hyperpara. So if you have suspicion of this one, you need to image the parathyroids. I will discuss on this as we go on, and also you need to evaluate other factors which are important to take a decision whether you need to remove the parathyroid gland. DEXA scan to see osteoporosis, renal function, because hypercalcemia can affect our kidney function. If somebody has hypercalcemia with low PTH, is not related to PTA. So we need to consider other causes like malignancy, other endocrine disease, granulomatous disease like sarcoidosis, and then vitamin D intoxication. So you need to do tests for these things like vitamin D level, PTH related peptide if that is available. Then you need to scan the bones to see whether there are osteoblastic deposits, X-rays, and then also other markers of malignancy, alkaline phosphatase, serum protein electrophoresis, which is high in myeloma, and the vitamin D metabolites, and then ACE level is for sarcoidosis, and thyroid, renal, adrenal functions if you suspect. Calcium excretion, particularly if you suspect this entity like calcium excretion disorders. So these are other advanced tests if you have hypercalcemia with low PTH. Management, again, it depends on the cause and severity. You need to stop any drugs, vitamins and calcium supplements that might precipitate or that may be the cause for hypercalcemia. And then if it is acute severe hypercalcemia, you need, it's a medical emergency. Rehydration will reduce some amount of calcium, particularly with normal saline, with CVP monitoring. Furosemide intravenous, this is a loop diuretic. This help to excrete calcium in the kidneys, particularly with combined with rehydration. This is useful. And then bisphosphonates are a group of drugs that inhibit osteoclasts. Pamidronate is one example. Then there are other drugs like zoledronic acid. This leads to inhibition of osteoclasts, and that will inhibit bone resorption. So that will help to reduce the calcium levels. Steroids, they inhibit the vitamin D action, particularly useful in sarcoidosis, lymphoma, myeloma, cancer-related hypercalcemia. And then calcitonin is the opposite hormone of parathormone. It was used to sort of treat hypercalcemia, but not usually commonly used nowadays. Then oral phosphate is given to bind calcium in the gut. So more calcium is, bound with phosphate and complexed and not absorbed in the gut. Mitromycin has also similar effects, and when severe, um, hypercalcemia, you need to remove calcium by dialysis. Then coming into localization of tumor in hyperparathyroidism, you can initially do a ultrasound scan. Sometimes in the very experienced hands, you might detect a parathyroid adenoma. But the gold standard in the imaging is to do what's called sesame B isotope uptake scan, where this in the sesame B, when you're given it, it is taken up by both the thyroids and also the parathyroids. And with time, it is taken out. It flushes out from the thyroid, and it remains in the parathyroid in the delayed scans. You can see in the delayed scans, the parathyroid remains, prominent, because the isotope remains longer in the parathyroid. So in that way, you can diagnose very convincingly whether it's a problem of one gland or multiple gland, and then based on that, you can refer the patient for surgery. So it's usually surgery that we do to manage parathyroidism. And if there is one gland, you can remove that. And if there is more than one gland, you can, what they do is they explore all the 4 glands and take off any tumorous glands and keep about half of a normal gland. Usually they take it out and then embed subcutaneously on a arm, so that if it again also becomes hyperactive, you can explore easily and take it off as well. So that's all about calcium disorders that we need to discuss. I have told you the important stuff, and then the small print stuff, which we are not usually commonly questioning at undergraduate endocrine module level. So I will send you the link, the recorded one, and I also asked Daupadi to upload the endocrine lectures immediately. Hypocalciuric this is the common one that we have mentioned is the familial hypocalciuric, that is calcium is excreted less, and this leads to hypercalcemia, right? So if this happens the other way, I think you may be asking, if there's too much of calcium excretion, whether this can happen the other way. Theoretically, yes, but practically, we don't see, patients too much like the familial hypocalciuric hypercalcemia. The reverse entity is not very commonly recognized clinically because maybe that there are a lot of other factors also involved, so that other factors may contribute to normalize the calcium level. So the opposite clinical syndrome is not much recognized in our clinical practice. It's the hypocalciuric hypercalcemia. Any questions other than that?